water is going to start moving in this way to balance out here, out. Okay? Because you've created a situation in the vein where the concentration is very low because you're using this hypotonic solution. So then your cells, same thing, right? Your cells are going to be drawing in water as well. So you're rehydrating the cellular level. So you remember this little thing, your little cell that you potentially dehydrated really badly? Now it's all, right? You have a hypertonic solution, and you're going to pump it back up, right? You're going to rehydrate. Think of a raisin. What was a raisin before it was a raisin?
Great.
It was great, right? So this is a dehydrated little cell. You can pull water back in there and rehydrate that little cell. Okay. So what's the risk with that?
Cell lysis.
Cell lysis. If you got a bunch of water shifting out into this area, your cells are going to start filling back up. You're going to start rehydrating, but you can go too far, right? It's all about balance. So this little cell now gets really big and fat, and then it can rupture. So you can help cell lysis if you go that way. So again, you guys, when you're giving these solutions, keep that in mind, right? You can take it too far the other way. And so, and especially when you're infusing something constantly, you're constantly changing that environment, right? So, let me think, what else should we talk about on that? Does that make sense?
Mm-hmm.
The whole movement of fluid and how it interacts.
Yeah.
So, another reason you give, say, a higher concentration of sodium chloride or NAS, what would be another situation? I think sort of main electrolytes, right? Sodium. What would be a situation when you want to decrease sodium? Yeah. You're hyponatremic. Hyponatremic. If your patient has a really low sodium, you might add some sodium by giving them 1% NAS, right? Because that's going to help. And it's also going to balance things out, but you also are going to be adding more sodium to the system. So that's another situation where you might use that. Likewise, you have hypernatremia. Give them a hypotonic solution, right? You've got a lot more in that solution. You have a lot more water, if you will, and a lot less sodium. What that's going to do is that's going to balance out the excessive sodium that's already there, right? It's going to pull it. So, a couple other situations when you would use a hyper versus a hypotonic. Now, real quick, we talked about colloids also, right? You guys remember what a colloid is? That's one of the main colloids that we give. Albumin. Right, it's got big proteins, right? Volume expanders. Blood or plasma is also considered a volume expander, but you're not going to give blood for every situation, right? You're going to give blood or plasma when you need to give blood or plasma. Albumin, because it's proteins, and if you look at that picture up there, those big proteins, they don't come in and out of here like water or like some of these other smaller molecules do. So think these bigger proteins here, those bigger proteins are also going to cause a shift in concentration. So in addition to staying in that vascular space, it's going to also cause a higher concentration intravascularly so that you're going to pull water into it so that you're going to continue to expand that volume, right? And it's going to stay there because these, as you can see up there, that colloid osmotic pressure, they don't move in and out as easily as the other stuff does. So if you have patients that are, in a critical care setting, many times you're battling with hypovolemia all the time just because you've got all kinds of things going on, right? You'll use colloids in between your isotonics to help with blood pressure. The colloids will stay in there longer, they'll have their blood pressure longer. So, but they also create this situation where you have a higher concentration intravascularly, so you also pull some of that fluid into the vessels. So, fluid volume